We'll be getting started momentarily. Hi, everyone, and welcome. I'm Liz Whitehead, Managing Editor at U.S. News and World Report. Thank you for joining today's webinar, Improving Mental Health on Campus, How Colleges Are Responding. Our experts will discuss how institutions around the country are addressing increased rates of students experiencing depression, anxiety, and other mental health issues with an array of enhanced and on-demand services, and by leveraging community partnerships in new, more effective ways. We are recording video of today's session and will be archiving the video on usnews.com. We are also simulcasting on Facebook, LinkedIn, and YouTube. Before welcoming today's panel, one final note. If you have questions, we ask that you please type them into the Q&A feature in Zoom on your screen. Later in the discussion, our moderator will try to give voice to some of these as time allows. Now, I'm pleased to introduce our outstanding panel. Dr. Shante Elbert, Associate Vice President for Health and Wellbeing, Ohio State University. John McPhee, Chief Executive Officer, the JED Foundation. Dr. Wendy Shanahan Richards, Chief Medical Officer, Aetna Student Health. And Dr. David Walden, Director, Counseling Center, Lecturer, Psychology Department, Hamilton College. Now I will turn the mic over to my colleague, Michael Morella, Managing Editor at U.S. News, who will moderate today's discussion. Michael?
Thanks so much, Liz. Thank you to our panel for being with us today and to our audience for joining. I really want to start by setting the scene. Even before the pandemic hit, a lot of colleges and universities across the country were reporting increases in students reporting depression, anxiety, suicidal thoughts, and other mental health challenges. Demand for mental health services, support, and staff on campuses has surged, and many say that it's reached crisis level. What have each of you seen at your own campuses or at the institutions that you work with? Could you help us kind of go around the horn and talk a little bit about what you're seeing? David, why don't we start with you?
Yeah, for sure. I'm happy to start. In terms of demand, we saw a bit of an uptick for us during the pandemic. That wasn't true of all institutions. Some saw a downturn in demand as folks turned to, they were home, they turned to local providers, so on and so forth. But we did see an uptick in demand. And I would also say we saw some dynamics. We saw different sets of needs. In the initial stage, we saw more of a need for connection, for services that supported connection. We did a few things here to try to meet those needs. And we also saw for us a creative response to that shifting set of needs and the shifting demand. We saw, and I think a lot of institutions saw a lot of creativity. We embraced virtual approaches, for example, to treatment. We embraced at our institution unique kinds of offerings that were meeting the demands of the moment. So we saw those shifts as well for us.
Shante, how about you at Ohio State?
We also saw an uptick here at our Columbus campus and also at our regional campuses in utilization. And because of that, we had to get just as creative as David mentioned in looking at some of our virtual and hybrid options for our students. And so Recreation offered some of the group fitness classes, mindfulness classes virtually, along with our Student Wellness Center, offered some of their coaching, peer coaching, some of the health and wellness coaching, some of our financial wellness coaching classes virtually. So we took a lot of that peer-to-peer support virtual, which was highly utilized. Some of the group and the Let's Talk through the counseling and consultation services was highly utilized. But more importantly, I think the biggest thing is that while it upticked, it was not too different from what we were expecting. But we did see a shift in some of our Black, Indigenous, and students of color in utilization in our virtual options through counseling, when historically they may not have used face-to-face counseling options. And in talking to other AVPs across the campus, across the country, they saw the same type of utilization that was historically not utilized by our Black, Indigenous students of color in those virtual options, and a demand for having more diverse, multilingual therapists who look like them. And so again, we started to see a necessity to make sure we try to hire or at least outsource or bring in third-party entities to serve those students' needs and wants.
John and Wendy, how about you, sort of zooming out and with the schools that you all work with? First of all, could you talk just briefly about kind of your roles at your organizations, and then just also what you're hearing from those schools and institutions you work with?
Sure. I'll start just because you said my name first. So at the JED, I'm the CEO of the JED Foundation, and we're a nonprofit organization that partners with high schools and colleges to help them look at all the different ways that they support student mental health and reduce risk for suicide. And we really focus on strategic planning, advising around how student mental health is supported. And the things we've seen are totally consistent with what we've heard so far. And I think it's important too that we all understand as we talk about college mental health, actually, that colleges are a great example of great work being done in many cases, and what really good community-based mental health care can look like, and that communities and other organizations outside of the education setting have a lot to learn from what's happening in higher ed. But what I would just add is, this issue that different students experienced very different things, in terms of how inequitable and different the impact was from a loss and a grief point of view, or financial impact, et cetera. There were students at some of the schools we work with who actually couldn't leave, even though they sent the students home, tried to send students, there was nowhere to go. And this idea that was raised about connection being so important, and trying to be creative around connection. So I would say that the customization was really critical in terms of how to make sure that no individual students in unique circumstances were falling through the cracks. And then, the idea of supporting students sort of with a village, right? Like, what does a culture of caring look like? With so many students now home, you lose touch points to notice them, to see them, and to recognize that they might need help. So shifting to models and sort of shifting to trainings that help faculty and staff recognize, like, what does distress look like through a screen, and how can we set up systems in ways that students will reach out. And I think one of the silver linings is what Shante said, which is that actually for many, the telemental health and the digital platforms were more comfortable and more culturally competent in many cases, and so actually created more connections to care than actually existed prior to the pandemic.
Wendy, how about yourself? What are you seeing?
Sure. Well, so as you asked, Aetna Student Health is a part of the larger CVS Health organization, and we partner with schools across the United States, colleges and universities, to provide healthcare benefits. And so we, even 2 years, 3 years leading up to the pandemic, we had seen an increased utilization of behavioral health services. We had instituted a dedicated clinical team to help our students navigate their benefit plans and navigate the healthcare systems, work very closely with our schools to ensure that, the programs that we have and the offerings that we have are in alignment with, their student population and with what the schools need as well. So we had already been seeing it. We've been ramping up, making sure we had telehealth in place, because some of the students did prefer to utilize telemental health and we have been hearing, we have a very close relationship with and a partnership with our schools, and we've been hearing from our campus counseling centers that they were beginning to feel overwhelmed because of the volume. They were bringing new providers on board, but the volume was so great, it was getting great before the pandemic, and then it just, as we've others talk about, really accelerated. And of course, there's the capability to refer to community-based providers, but we are also finding, again, even before the pandemic, that a number of the practices were closed to new patients, or it took some time to set up a first-time visit with a provider. So we have a dedicated network manager. She works very closely with our company's provider network team to help recruit providers who are interested in coming into the network, and also so that we could point our students to the resources that they So all of this was kind of in play before the pandemic, and then we saw, starting in spring of 2020, really things started to accelerate.
I would add two things to that, Michael, which one is that just zooming out even further, I think one of the things the pandemic did, and some of the data we have from like the CCMH data, suggests that the pandemic exacerbated existing problems. It certainly presented new ones, that we all shared and experienced, but it highlighted existing issues. It attenuated them, right? Turned up the volume on the last 7 years of increased demand and acuity that was already happening. And then the other piece for me is that it also highlighted, and I think we're seeing this play out in what employees want and in what students want, and this sort of, we're at this point of kind of a little bit of shifting in the field, right? It highlighted what's fundamentally important. I think a lot of us had to face that in our own individual lives, but I think it helped with the field as well, sort of say, what are we really wanting to do here, with this field? Because I think something that's global and right as big as a pandemic has, any crisis provides that opportunity, right? To really tune into, what do I really need? Who am I really?
Absolutely. I actually, picking up on that point, David, and a number of you have mentioned ideas, building connectivity, hybrid programs, peer-to-peer. Let's kind of unpack those a little bit more and sort of be as forward-looking as we possibly can. We're in this back to school moment. People are returning to campuses and classrooms across the country. What are some of those lessons that you all have learned or are still learning that might be solutions, whether they're in the sort of medium term or the longer term, or ways that you're kind of taking some of these things and what you've seen even prior to the pandemic and understanding or reinventing how you all work and who you all work with. Again, very broad and open-ended question, but let's hear from each of you and kind of examine that a little bit deeper.
Michael, I can talk about this all day.
Please.
I think the first thing is that it's caused us to re-examine the approaches that we take. And for me, is looking at it from a very population level public health model. We've been very treatment, reactive focused, and in public health, we say, let's go upstream, but we really haven't taken that approach. And so you talked about the data saying increased anxiety, increased depression, but we haven't done a root cause analysis because all those surveys that we did in the midst of COVID didn't have subsequent questions that asked and pinpoint, was it caused by COVID? Or was it caused by COVID and social and systemic unrest? Was it caused by racism? And so, as David mentioned, yes, we brought in more therapists, but we didn't bring in more clinicians in student health. We didn't bring in more preventionists in disability and student wellness or recreation. And so we just threw more therapists at it, assuming that that was the need, versus actually sitting down, talking with students and bringing them to the table, which is, again, a population public health approach is ask them what they want so we can, again, have them at the table to meet their needs. And so, I always give the example of when I moved here, I took my biometric scan and my health assessment and asked within the past 30 days, have you been stressed? Yes, I just moved across the country in the middle of COVID with a husband, a 10-year-old and a 3-year-old. Yes. But then when I looked at our data at the end of the year, and it said it was a drastic increase in staff and faculty stress and anxiety. I know I said yes, but we didn't pinpoint. And so one of the things, you can quote me on this, I say we do really good leaf work, but we don't do really good root analysis or root work, as we say back home in the South. And so I would like for us to get to the branches. If we can get to the trunk of the tree, and in higher ed, it would be really great if we can get to the roots. And so that means looking at how we approach the work that we do from a very equity-focused, health equity-focused lens. Yes, some campuses need more therapists, but if we have been hiring ourselves through therapists, but haven't looked at it from a prevention-focused approach, we still haven't went upstream. We still haven't helped students understand a non-medical model approach to health and well-being. And so we now are telling students the best way to get through trauma and hurt or challenging situations is through a therapist. And that's not the answer, because we know when they graduate, the traditional healthcare model cannot sustain that. So we have also created a problem that when they graduate, the traditional model outside of our walls of higher ed cannot sustain what we are now creating in higher ed. And I'll stop there for now.
Oh, I would just amen to most all of that. And add on to that a couple of different things. So just to underscore some of the points that Shantae just made, there is data that says, and I'm forgetting where this is coming from in this moment, but there's, I think it's NASPA data that, some 35% of folks in student affairs don't know if they're going to be in the field within the next 5 years.
It's from NASPA's report, David.
There's good. There's AUCCCD data that says, the Directors Organization for Counseling Centers, that 60% of centers lost one or more people in the past year. 70% of those centers are having trouble filling the position. There's also data that says some 90+% of college counselors are burnt out. So just to put numbers to some of that, some of that texture, right? And to me, what all of this says, there's a zoom in and a zoom out to your question, right? So the zoom in is, we were creative. At Hamilton, we created something called, at first, quarantine pantry. We decided people were isolated in their dorm rooms. We wanted to create something that our dietitian led, and out of our office, we gave away free boxes of farm fresh ingredients to students. And then we had a Zoom cook along so that everybody could, it was gorgeous. It was beautiful. People were doing accents with each other and playing and, oh, hi, so on and so forth. It was lovely. We did a bunch of things like that. We created a songwriting therapy outlet, a number of different virtual offerings, right, that met the needs of the moment. That's the zoom in. We partnered with some third-party organizations to diversify our counselors, and it was the right moment to do it because we were all virtual, and it was kind of perfect for that. So all of that was wonderful. But then to zoom back out to this conversation we're having, I liked the way that you said it, Shantae, because to me, the way I say it is that we have had a conversation around meeting demand for many years. And that conversation has now outlived its usefulness. That question of meeting demand, it's not that it's bottomless. I believe that there are ways to quantify it, and there are ways to be thoughtful about what your center is going to serve, and what your institution is going to serve. But I think the question of how are we going to meet demand is no longer the question. To me, the question is, what are we going to be and what are we not going to be, right?
Exactly.
There's this moment of boundaries that's really important to articulate. And so for me, the conversation, the zoom out answer to that is that one of the things that's maybe the most important thing we have to do is provide a meaningful place for people to work. Because without providers in our centers and in student affairs in general, the rest of these conversations are moot, right? So we have to figure out what is an intentional, strategic approach and philosophy to what our institution is and isn't, and what we're going to provide and not provide, that will support our staff and provide meaningful services to our students. And so I think that boundary piece is important. And the last piece, and then I will also, I think it's also generationally appropriate. I think this generation speaks a language of boundaries. I think they establish boundaries in ways that maybe I didn't, in my life. And so I think it's generationally appropriate for us to use that language and also to model that behavior as institutions, to say there are just some things we can't do, we can't be to folks. So I think that's a really important solution,
Yeah, Wendy, John, I see a lot of nods. Do you any other perspective on this as we're kind of throwing out solutions and calls to action? What have you been seeing, or what do you think is sort of a possible path forward?
And Wendy, you want to start?
Sure. I think we talked a little bit about telehealth, and we saw the utilization from our standpoint increase over 9 times between 2019. And even as the pandemic has moved on to different stages, we are still seeing a significant utilization, not quite as much in terms of magnitude, but still seeing utilization. And and we don't believe it's going to go away. So even with campuses fully open, people going back to, doing what they used to do before the pandemic started, that type of thing. And so what we've been doing is making sure that we are providing, the adequate access to telehealth, because again, that's what our schools, that's what our students are telling us, either directly or indirectly, that they really want to have going into the future. We've also, we have developed a well-being portal that is on our Student Health website, and it can be utilized by any student in the university. They don't have to be covered under one of our health insurance plans. And the mental health section and the emotional well-being section is the biggest of all 6 dimensions, because there is so much information to be able to provide. And Shante spoke about preventive mental health, and I think the awareness and again, making resources available so people can read about this and say, oh, yeah, that's how I've been feeling. There's nothing wrong with feeling that way if I can make sure I'm going to get some assistance. Let me talk to somebody. And we've seen an increase in utilization of some of the tools on that site, our anxiety and depression screeners for some of our students that had not previously been seeking health services. So and again, and I think the only other thing I'll mention here too is that we make sure, and we continue, of course, to make sure that our member services area who are dedicated to our students, to our business within our company, to our members, as well as our clinicians, our case managers, are well equipped to make sure that they can help students navigate through the healthcare system, which in and of itself, throughout the whole pandemic has just been quite a bit of stress. So those are the things that we're doing, and I think I'll end by saying that it's important that we listen. We don't provide healthcare. David and Shante, you and your teams do. So we listen to our schools and our students. We want to make sure that we are doing what we can the best way to support their needs as they're successfully going through their educational period.
Yeah, and I'll just add a couple of things. Picking up on Shantae's comment about a public health approach. I think this is a really key point that when you think about how to support mental health, you need a model, right? And the model should be a public health approach. And the decision makers at a school have got to align around such a model. At the JED Foundation, we call it a comprehensive approach to mental health and suicide prevention. So that when you think tactically about what to do, nothing's being missed, right? You're catching everything. The things like developing life skills and promoting that sense of connectedness that David talked about, and belonging, and reducing stigma in a culture of caring, but also looking at how do you notice a student is struggling and how do you get them to care? The whole system model is needed. Then what we recommend is that there's an interdisciplinary leadership team that oversees mental health planning, that's helping the mental health services leaders, so that faculty is engaged, and different key departments like Res Life and athletics are engaged. And as Shante said, students are engaged and on the committee, so that you're sending this message that this belongs to everybody and it's everyone's responsibility, even if mental health services is not in their role description. And the data is also critical, because in really trying to do quantitative surveys, things like Healthy Minds or the National College Health Assessment, so that you can understand what's happening with the student population. Focus groups. You really want to understand, who, and from an equity point of view, who was that school built for and who wasn't it built for, and be honest about that, so that you can tailor approaches to best support the students that are there. So those are the things I would add. And just with one final note, which is, in all of this planning around it, is not to forget the very specific suicide prevention activity of means restriction. Really auditing the campus and looking for whether it's rooftops or chemicals in labs or window guards, whatever it may be. Every environment is different, but systematically making sure that the potential means for suicide are hard to access, because we know that that suicidal impulse can be fleeting, and we want to make sure that it's as difficult as possible to gain access to lethal means in that moment.
We have a question from someone in our audience, and I think it's an appropriate time to ask it. Thinking about what's available, what you're learning and discovering, sometimes by necessity in these last couple of years, but in instances where a student doesn't have access to a therapist or doesn't have access to support on campus, our audience member asks, how are you going to teach and help students to care for themselves mentally and emotionally in absence of such a therapist? Anyone want to start with that? Shantae, please.
So I know we're going to talk about health equity, but I'm gonna give a caveat here, because I think a big piece that people keep saying with prevention is that everybody needs resiliency. But when you think about health equity, is that some populations already have an extra abnormal amount of resiliency. And I think about generational trauma. And when you look at SOTERA's 2006 generational trauma framework, the key piece in the middle of that framework talks about how they build protective factors, and resiliency is part of it. And so when you approach certain populations, specifically low SES, first generation students, our students of color, and then you approach them and say, you need more resiliency. You already discounted the things they had to overcome prior to coming to our campuses. So when I think about that question, it's meeting them where they are and saying, well, what did you do to get here? Let's start there, because you are already amazing. And again, I think about using motivational interviewing. I'm a health and wellness coach, and using positive affirmations to remind them of what they've already accomplished. And then again, going from there and giving them those skills around from there, and then referring to the counselor to build from there to deal with the trauma, anything around those serious aspects of it. But that peer-to-peer approach and that health and wellness coaching can meet that need and help them build their tool belt around those dimensions. Some campuses have 7, some have up to 10. How many dimensions you have? Let's fill that toolbox so they can know that, as my twin talks about, play the whole keyboard. Every emotion is there for you to try it out, because sometimes that privilege was not given to our students. And so I think coming to our campuses, when we talk about identity development, so is emotional development. And so we give them a chance to figure out that they can develop those emotional, those psychosocial skills that they were not potentially given opportunities because of their family and their community upbringing. But for me, as a first-gen student raised by my community and my family, I was already resilient. And so it is kind of off-putting when I hear people say, well, how do we teach them? Well, what do they already have? And how do we build from there? Because I think a lot of times we have this kind of bootstrap mentality that all of our students need all of these things, but they don't. We need to be mindful that there are specific approaches that we need to take for certain populations, and then we can have broad, widespread programming like we do for our Title IX consent-based programming. But just even within that framework, we do different programs for those who are already being victimized and now are survivors. Same thing for mental health and well-being. We have to figure out where they are, so we do need better assessments. That's why I'm so happy here on our campus. I've been working with our assessment team to build our own social determinants of health assessment for our students that we'll launch next year, because we need to know what has impacted our students around those social determinants of health so that we can better program and do outreach for our students. Now I'll let you go, David.
Well, yeah, I'll begin with, I couldn't agree more about the piece around resilience, because one way that we could talk about that is maybe anxiety, maybe depression, maybe a trauma reaction, maybe all that is very appropriate to what someone has experienced in life, right? Or what is going on in the world, right? And to sort of put out there that resilience is needed is almost asking someone to do additional emotional labor on top of the emotional labor they've already done. So start with that. The question is a good one. So this question of what do we do in the absence of a therapist? To me, what we're talking about life skills, and I'm going off of what Shantae was sharing. We're talking about skills that a lot of folks can teach. So a licensed therapist is a specific kind of resource for specific kinds of needs. And one of the phenomenon we've seen recently is that a lot of things are now defined as a mental health problem. And I think to the extent that that means that we are able to talk about our inner worlds in a wider way, in the same way we have been able now to talk about our gender identities in a wider way, right? Our racial identities in a wider way than we were 20 and 30 years ago. To the extent that we're able to talk about our inner worlds in a wider way, calling everything mental health is great. That's a lovely move. To the extent that it means that everything now needs a licensed therapist, that's not great, right? So to me, how do we teach students these skills, or how do we meet those other needs as appropriate for those populations? An example of that on our campus would be, we have support specialists that work through various offices on our campus that are focused on specific populations. Those support, one example is an LGBTQIA plus support specialist on our campus. So this person can answer very specific questions about that life journey, you know, that sure, some of our therapists could answer as well, but that partnership allows our office to provide good treatment and good therapy, and it allows that office to answer those specific questions if that student can't find an LGBTQIA plus defined therapist, you know, or they're just not comfortable talking about it with their therapist, whatever it is. That partnership allows us to get out of this dialogue of like, well, let's hire more therapists, you know. It's like, well, no, let's hire those other kinds of supports, which also gets to a resource allocation question that we have. But that's an
Yeah.
example, yeah.
But yeah, I didn't mean to interrupt you. I actually, let's drill down into partnerships a little bit, because again, you all have alluded to this, but I know you all also have a lot of things going on across campus, between campus and the community, or across the country. Wendy, could you start us off and talk a little bit about some of Aetna Student Health's partnerships? I know you have one with the ACHA and otherwise. You know, what are you kind of learning from the value and the power of those kinds of partnerships, whether they're at the institutional level or much broader?
I would say, you know, for us, you know, top priority is at the institutional level with our schools. I mentioned that in the beginning, you know, that we do work to have a strong partnership with our schools, and want to make sure that, again, that we are offering the type of programs and products that meet the needs, and, you know, and work with this unique population. You know, when we're looking at a population of, you know, young adults, returning students who may not be young adults anymore, but they're returning students. There are so many different and diverse needs that, in order to serve, you know, again, our population the way we really want to and need to, we definitely need to make sure that we continue the strong partnerships going forward. I think, you know, the other thing too is our providers. You know, again, whether they're healthcare providers on campuses or, you know, in the community. Again, very, very important. Never want to leave our providers out of the, you know, the whole circle, because, again, without people who have the skills and, you know, the desire, you know, and the strength to take care of people, you know, the healthcare system. So definitely there. And then, you know, I think in terms of, you mentioned about our schools, and I'm sure that, you know, David and Shante can add, you know, a lot more information to this, but, you know, certainly during the pandemic, a number of our schools, you know, were working very closely with their local public health, you know, association, department and such to keep campus safe. We've, and you know, I know a number of you are working with the American College Health Association, as are a number of our schools too. We've also seen partnerships between, you know, we have a partnership within our company with American Society for Suicide Prevention, utilize some of their great tools. I know some of our schools do too, and then, you know, mental health first aid, you know, training for campus has been something that, you know, our schools have well. So I can speak now about the ACHA and ACHF partnership, or we can save that.
Yeah, actually, you tell us briefly, please.
Okay. Well, so, you know, I love the ACHA website, and we talked about resources, and I have just found so much useful information there, and I can't say enough about it. You know, there's, you know, continuing education courses, and there's webinars, and I know that a number of our schools, you know, have told us that, you know, it's a great opportunity. That organization really promotes, you know, sharing and collaboration between the schools, which again, I know Dave and Shantae can speak to, even more so. So that has been very, very helpful to us. A lot of resources, and then we have had an ongoing partnership with the American College Health Foundation. We've partnered with them, and we're actually on our way, just about ready to publish a third white paper. We started off by assessing kind of what is well-being like. What is the programming around well-being on the college campus setting? In some key takeaways, there wasn't, one, uniform definition of what well-being is. It's discussed in different ways and in different settings, which is fine. And one key takeaway too was that there really wasn't a tool out there that everyone was a consensus with that to measure kind of the impact of well-being programming. And this is what we heard directly from the schools that participated, in our study. And then from there, we, in terms of the measurement piece, we took that a step further to say there are a lot of really good validated measurement instruments out there, but is there a way to take the best of the best and bring that together into one survey instrument, particularly around emotional well-being? Because our schools, again, have told us, everything's important, but this has really risen to the top as key, as far as assessing, the level of emotional well-being and what can be done with the programming to impact that even more so than currently. So we published that white paper as well. And then, again, our third is really looking at the effects of environment on emotional well-being, diversity, equity, inclusion, all of the, we've heard about today, so important, and looking across not only students but faculty and staff as well. So, I don't want to spoil things by talking about the results. You'll see that as it comes out on the ACHF website probably within the next. So it's been a great partnership. It's been a strong partnership. I know I certainly have learned a lot, and we hope to continue.
Something certainly to keep our eye on. John, I want to pivot back to you. I know we've covered a lot of ground, and
we have. I'm going to say three things, I think,
Please.
just sort of quickly that come to mind in this. So, the first observation, I guess, is that a couple of things have shifted, and these have been mentioned, and I think it's important when we think about planning around mental health. One is, if we go back a few years, I would argue that when we talked about mental health among young people, among young adults, it was related to the fact that this is the age of expression for mental illness, and that there's an 8 to 10 year delay in the diagnosis of mental illness from the emergence of the first symptoms. And so the work was really around trying to identify that emerging mental illness and get the person to mental health care. And that remains incredibly important today. But when we talk about today in the context of the pandemic and racial violence and bias and prejudice and police violence and climate change and a loss of reproductive rights and the many other things that I'm forgetting that are causing a lot of upset and anxiety, fear among teens and young adults, we have to be very careful not to pathologize those things. And as David said, that don't necessarily require behavioral healthcare intervention, but they are part of the experience, part of the trauma, and need tending to. And so how we define mental health and how we think about it, the JED Foundation, it's anything that causes distress to a teen or young adult is in scope. And I know that's very broad, but that's nonetheless, how we think about it. And I think it's also important for those of us that are in positions that are messaging and talking to young adults and teens about mental health, that if we're not clear that the upset is a normal response, has been discussed here, and still might need care, we lose our credibility, and so it's really, I think there's a really important sort of moment here around how this is all talked about and conceived and thought about, and we need to meet young people where they are. I think they're ahead of us on this point. And then the other thing I would just say is that we know we have a big supply side problem for behavioral healthcare workers. We have a shortage. and so even for those who need behavioral health care, it's really hard to access, to be affordable, to be culturally competent, et cetera. And so we used to talk about help seeking all the time. If you are struggling with a mental health issue, don't be ashamed, be brave, it's courageous, reach out for help. I would argue, I think it's important now that we start focusing more on help giving and, how we all can play a role in supporting the people around us and using COVID and what's happened to talk about our own mental health and to sort of, be part of a safety net for one another. And I think that's part of prevention. The conversations happen earlier. We feel like we're supported in a way, because we have to figure out how to create that culture of caring that's upstream, that's more interwoven into what we all do, because it's not going to be solved by therapists, as has been, discussed. It needs to become more the fabric of what we all do. And the last thing you asked about partners, I just want to say there are many great nonprofits in this space that, the JED Foundation, where I work, but Active Minds, the Steve Fund, Bring Change to Mind. There are a lot of resources and good partnership opportunities in the nonprofit charity space for schools to partner with.
Shante, did you have a point to add? I wanted to turn to you next, but I don't want to.
I mean, they mentioned American College Health Association, JED Foundation, NASPA, ACUD. I mean, all these organizations, NERSA, all of our national professional organizations, ACPA, are good ways to connect and bridge the gaps, at least within the institutions of higher education. But I think the piece that is missing is now to bridge the other side of it, like APHA and the other professional organizations of those who do our work outside of institutions of higher ed. And I just had a good conversation yesterday with our director of counseling, Dr. Sharma, about the hiring issues that David talked about with counseling center directors. And I was talking about my twin who practiced and did really great work in the community and wanted to transition over. And it was, if you didn't come up through higher ed, you couldn't become a director over counseling. And now that there's a crisis, the doors have opened. So we created the problem that we're now having to some degree with that pipeline of having a niche of what type of counselor and director we wanted in our counseling centers, when those in the community were seeing the diversity of acuity that we're seeing on campus quicker and sooner. And so they were already reacting to some degree, and we were kind of being reactive to some degree. One thing I love that Dr. Sharma does here is every year he brings our community partners that often our students are referred to on campus. And there's a day-long education, professional development series that they do with our partners within behavioral health. And that's an easy way to do it, but it also is a good recruitment. If we have physicians, because again, when we have physicians, they already engaging with our team here, and it's a great way to be collegial. But I've also had to work with my supervisor, Dr. Shivers, who's been great, in our HR to increase salaries. We got to increase the salaries because these third-party organizations can pay them a lot more to sit at home and do private practice. And higher ed is slow to pick up on the salaries. So we got to increase the salaries of our healers on campus, because that is just as important as everything else that we do. And as we do this work, in tandem, we do the work for our faculty and staff to give them a livable wage and to make sure they have resources and they are able to work hybrid schedules if possible, and they can have time off to have mental health days. All those things are done in conjunction because they have to model the behavior so the students can see them thriving in the classroom as faculty and staff. If they don't see it within the classroom, it's hard to, it sounds kind of productive when they say, oh, you rest when you go home after you do my homework that I've assigned for you, when they don't see the faculty taking their own mental health or wellness days. And so you have to have, as you mentioned, Michael, an interdisciplinary team who's looking at the whole continuum of care on campus. And we have a One University Health and Wellness Committee. Our president called together our Commission on Mental Health that is still ongoing, working through our recommendations. I lead our subgroup 4. And many campuses have a commission, are working through recommendations, but you have to do something. And I think it has to be from the top down and the bottom up. And our commission had faculty, staff, and students. And each subgroup has faculty, staff, and students, undergrad, grad, and professional. And so when you have everybody at the table working through recommendations and moving the campus forward, it's all hands on deck. The buy-in is there. And then you have to have the funding to move those recommendations forward. It has to be part of the budget. So that way it is just as important as the other components as safety. Health and safety are integral to the pulse and the vibrancy of a campus, because now we know that that's what parents and students and families are looking for when they come to an institution. And in that, it also is a great way for us to recruit. It's hard for David and I to recruit people when our campuses are not setting up the stage for us to have great elevator speeches to showcase how we are creating equitable spaces for not just self-care, but self-comfort, like really good work, not just the stuff that we Google, oh, that's self-care, I just got a massage, but no, I'm actually getting to the root of what's causing harm, why I can't show up as my authentic self at work. And so getting beyond surface level work and getting to the comfort level where I get rejuvenated, and when I come to work the next day, I actually want to be here and didn't have to count to 10 before I got out my car. And so that for me is that continuum of care of what we really want to do in higher ed, because then we create global citizens who are the next clinicians, the next preventionists, the next researchers who will shift the dynamic that we really need here within the US and globally.
I want to, you anticipated my next question, Jantea, and really we've got a couple people in our audience who are asking. I want to make sure we explicitly talk about this for just a couple minutes, but how do you take care of staff and think about some of the things? Again, you all have tossed out some great ideas and some important things to consider, but somebody in our audience asked, what more do colleges and universities need to do systemically to address burnout, retention, and create that kind of meaningful place to work where it's evident to somebody you're trying to recruit or somebody you're trying to retain? Any other thoughts on that? David, do you have anything from your own campus's perspective?
I think the big framing is that the great paradox of mental health and higher education right now is that it's never had a higher profile, arguably never had a higher profile, and institutions are not remaining competitive with the other opportunities for specifically mental health providers. So it's a very strange paradox. It's never been more important to many constituencies, and we've never had a harder time staying competitive. The data that I have from some surveys with Mantra Health of providers is that in the first part of the pandemic, when we started asking, they were looking for connection and cohesion, much the same way our students were. As the needs shifted, what people seem to be wanting, and I'm sure other folks have data on this too, is they're wanting flexibility, they're wanting remote work options, and I think this is the phrase we want to unpack, Michael. It's they want a meaningful place to work where they can exercise their skills and their training, right, that they authentically can exercise. And to me, to put a little texture on that and then to kick it to others, providing a meaningful place to work, I think all of us have experienced, for example, needing to package ourselves in certain ways at work, needing to put energy into presenting, that I'm together, that I'm okay, that I'm going to produce, and so on and so forth. One example is to provide developmentally appropriate spaces where people can be themselves, where people are allowed to come to work as full humans, and it is valued that they have life struggles, that they have growth edges, that they have things that are bothering them, that they are working through, so that the energy that usually goes, and this is the therapist speaking, but the energy that usually goes to presenting or defending can then be put towards the work, or can then be put towards self-care and self-love, So to me, this maybe is an unsatisfying part of my answer, but it does feel like it's really important for us to adopt in our individual institutions an ethos of care for the whole person, an ethos of saying it's all right to be a human being at work, that your story is important, and that your individual needs are important. And there are boundaries around that are obvious around the functions of the workplace. But that just feels, that ethos, that shift, people are looking for that, and they will find organizations, companies, right, that provide it if we're not going to provide it.
We've only got about 10 minutes left. And again, I know we could spend a lot more time on each of these questions, but I want to make some time for at least a couple bit more. One is somebody in our audience asked, and I was thinking of a similar question, what are some effective strategies? What's worked with you, David, Shantae, on campus, or John, Wendy, campuses you work with, for advocating to senior leadership to invest sustainably in what's needed? And, even when things are changing all the time, and this, the demand challenges, the supply side challenges were what they were prior to 2020. Any thoughts there for this member of our audience? John, I don't want to pick on you, but I will.
Sure. The first thought that comes to mind is, this work caring for the mental health of students and faculty and staff, it costs money. And I'll just, maybe this is obvious, but, just note that, the telemental health and the digital mental health, which I think has enormous promise, which sort of started with this idea that it was going to augment and be able to supplement what schools are doing, has turned into a competitor for the talent, and is in some ways aggravating the supply side problem, at schools. That's just an observation that schools have to I guess, realize. But this work, though, directly supports student retention and student graduation. And so I think when looking at the ROI on the investments, there's work out of the Healthy Minds Network at the University of Michigan. We have data at JED that we have not yet published yet that shows JED campuses are seeing, after they do this work, improvements in first-year retention and sixth-year graduation rates, which I think we all understand makes sense. But from an investment perspective, I think that needs to be part of the argument, or just part of the case about these investments. They really do pay dividends, and they really do support student success, which then supports, has significant financial and other benefits to the school, in addition to the extraordinarily important and primary benefit of supporting the mental health of the students and the faculty and staff.
Wendy, someone in our audience is asking if you could kind of remind us again, or say explicitly where they might be able to access some of those white papers that you mentioned before. Is that at the Aetna Student Health website, or?
It's actually at the American College Health Foundation website. Okay. There's links to paper, the first and second paper, and there will be a link to the third paper.
Great, thank you. American College Health Foundation website, great.
Michael, that question of how do we, because I think the question was, how do we advocate up to higher administration, right? To me, it's really important to recognize that the folks in higher education, at least in my experience at 3 different institutions, is that folks really care, despite some of the narratives that can develop on a campus, out of anger and pain. Folks are really trying just to do their best to meet need. And one of the ways that I think it could be helpful to advocate up around a more strategic or intentional or thoughtful philosophy and approach is just to say, hey, this is a big problem, and we have sort of met the logical conclusion of the meet demand question. And maybe one of the reasons to invest in a broader set of resources is that that's what's going to allow us to achieve a fairly stable state in how we respond to these concerns. If we keep saying meet demand, then you're going to keep giving me therapists, and while I might want therapists for anyone listening out there, I thought I'd try a joke. I think the answer is obviously investing in other units on campus, right? And so I think one way to sort of advocate to an upper administrator who's really trying to deal with a multiplicity of problems and track a lot of different issues is to say, hey, if we sit down and decide who we are and who we aren't, and what we're going to provide and what we're not, we can sort of gauge that using some data with Healthy Minds and other data. We can establish a program that we're resourcing in the counseling office and in other offices, and then have that be a somewhat stable state, right? Because we're saying we're not going to be all things to all people, right? And this is what we're going to do. And then the last piece of that for me to sell is that this is also what's needed is alignment, that we make those decisions and then we align our messaging to prospective students and families and current students and faculty and staff and our individual service providers. We align that messaging, right? up and down, so that everybody knows what to expect. And to me, when you do that, especially in today's generation, you can have folks that aren't happy with the limitations that you put out there, but they understand. When you explain honestly, like, this is what I'm facing and this is what I can and can't do, I found folks are much more willing to embrace that than when you go, well, we're really trying to wrap our arms around every student need, and that just conveys the message that we can, and that sets people up for disappointment. And so to me, I think being able to say that to someone who's trying to manage all these different problems is helpful, to say, hey, I think there's a sustainable answer here, for us, right?
If I can add to that, I mean, I'm grateful for President Johnson and Dr. Shivers. This is a breath of fresh air to be here, to have a comprehensive approach and a team to look at student health, well-being, and safety from a lens of, let's look at the data, let's bring in everyone across campus. And so for me, I want to emphasize one thing we haven't talked about, which is the faculty, and specifically the faculty within the health sciences programs that are often our interns, our volunteers, or our fellows in some of our departments, and creating more streamlined. I think counseling has probably, because APA accredited programs have fellowships and internships, but how do we create more pathways into our offices on our campuses, especially for diversifying people who work within institutions of higher ed? Better pipelines can be useful. So I think that's the biggest piece for me, in also helping faculty by creating workshops on how to integrate cultures of care within their classrooms, how to integrate it within their syllabi, because again, these are things that they can naturally do without fully changing their syllabus, because they are already doing great work already. How can we emphasize it even more? Those are pieces that we haven't mentioned. And I think that I want to emphasize those pieces because I also teach, because clearly I'm not busy, but teaching MPH students has been a breath of fresh air, because they often forget about our setting in higher ed. They may have used it in undergrad, but they forget that they can also work here after they graduate. And a lot of times they don't know how to get their foot back in the door. And so that recruitment piece is pivotal. And we got to talk about our recruitment practices so we can look at how we are recruiting and retaining those within these positions. There are some positions that should not require a master's degree, and so we fix the equity within salaries. That's just the first piece. We also have to stop relying on volunteerism for some of our positions that are pivotal, like for our peer-to-peer support. Yes, some should be volunteer, but we should start funding some of these peer-to-peer roles with some salaries, or encouraging more of our work study students to do it. It has to be a tiered approach to it. So I think it has to be comprehensively approached in how we look at this work. And then more importantly, working with faculty who are writing grants. It always baffles me when faculty get grants for the work that we're doing, and they're like, oh, I didn't know y'all were doing that across campus. And so that's a big piece that is often forgotten, that they're writing and doing research on the work for our age and our population of students, where we could partner a lot easier. So it's very important to do that, that in-house work. And so that way there's probably already money there potentially with faculty that is often left out or left on the table.
I have to be cruel here and kind of bring us to a close, because there's a lot more we can say. Shante, thank you for bringing in the faculty piece of the conversation, but I just want to pitch a quick final comment from each of you. Is there something we haven't talked about, or you really want to underscore as a takeaway for parents, prospective students, your peers on campuses or with other higher ed or public health organizations? Let's close it out this way. Wendy, do you have a quick thought you could end us on?
Well, I think we've heard about a lot of resources that have been brought to bear, and more to come down the line. And I would say ask all the questions as an incoming student and as a parent that you can, to make sure that what you're looking for is, at least if it's not there, it's part of the future strategy.
David, any?
two things. One is I work at a place, to echo something Shantae just said, where I feel seen, I feel supported, I feel valued, I feel resourced. That is worth its weight in gold. I also work in a beautiful facility, which helps, but that's critically important moving forward. And the other thing, I've been, ever since the pandemic started, I've been living by this motto of kindness to myself and grace to others. We're all under a lot of stress. So kindness to ourselves and grace to others.
Great perspective. John, how about yourself?
Just two things. One is, pandemic and everything that's been happening, I think has given us an opportunity to openly talk about mental health and sort of, put the stigma to the side. So let's make sure we run through that door. I think that's a silver lining or a benefit. And then the other is to repeat a comment I said at the beginning, which is in this discussion to make sure that we acknowledge that there's really great work happening in mental health in higher education. And that when we think about a public health approach and a community-based approach, some of what's happening in higher ed across the country is actually a model, I think, for other settings and for our communities as a whole.
And Shantae, how about yourself?
John took some of the words, but one of my mentors often says, Dr. Battle, that public health and this work is a team sport. We can't do this work in silos. We can't do this work from one specific lens or area of expertise. We have to have an interdisciplinary approach to looking at this comprehensively and building cultures of care. And so when you look around the table, if the table is homogenous and doesn't represent the students that you serve, then you need to go outside of your campus into the community to bring the people to the table to make sure that the access meets the students' needs. And if you can't, as David has mentioned, you must have seen some of my PowerPoints. Ethically, we need to communicate what we can and can't do. And for those who are looking at institutions, sometimes the institutions can't serve your student appropriately, and making sure that you find a place that they can thrive. And you may have to find a different campus, unfortunately, because the budgets are really strained for a lot of campuses right now. And it's not that they don't want to do good work, but that's just the reality where a lot of us are. And even outside in traditional healthcare models, they are having the same type of conversations. And so that extending grace, David, to all of us is going to be very important. And everybody needs to roll their sleeves up and do this work, but also take the time to get some self-comfort, get to the root, develop your plan, and making sure you communicate with your student about what they need prior to coming to our campus, because we can't be all things for your student.
Well, I think that's a great note to end it on. I want to thank you all for coming to this virtual table, sharing your ideas with us. And thank you those of you in our audience who joined us and who had some great questions. You can find more about our speakers and future webinars at usnews.com/events. But thank you all for being with us today, and look forward to the next time.
Thank you.